Welcome to the lecture about anesthesia for ATS. I think you'll find this topic interesting as there are special considerations for ATS for anesthesiologists. I'll not be discussing off-label drug usage, and I have no financial interest to disclose. I'll briefly mention the genetic causes of ATS, outline the tissue defects associated with ATS, and then discuss the anesthetic implications. As many of you already know, ATS occurs due to a gene defect causing a deficiency of the GLUT10 protein. As a result, some parts of tissues grow too much, as GLUT10 protein normally acts to restrict growth of some tissues to prevent overgrowth. Lack of growth restriction results in defective tissues that cause disease. Some of these defects are important considerations for anesthesiologists. In particular, GLUT10 protein puts the brakes on the development of blood vessels, bone, and soft tissues, including muscles. Without GLUT10, overgrowth of arteries, deformations of bones and joints, poor muscle tone, weak airway walls, and hernias of various kinds can result. In preparing for anesthesia, a complete review of the medical record is necessary to identify all organ system dysfunctions of ATS. Sometimes we need to check with other specialists for details. It helps to see the patient in advance and particularly speak with the family so that we can prepare for special equipment or medications for that particular patient. Each anesthetic for an ATS patient is a designer anesthetic based on the condition of that patient at that time for that anesthetic. Since ATS is a progressive disease, different preparations may be in order than were needed for a previous anesthetic. We review everything with special attention to organ systems affected by ATS. Being anesthesiologists, given that we often breathe for our patients, we have a particular interest in the airway. Our upper airway evaluation includes a history of snoring or apnea spells while asleep, difficulties with previous anesthetics, particularly in placing a breathing tube. We also pay close attention to some of the things that are associated with ATS, such as a short jaw, also known as micrognathia, and a high arched palate. Both of these things make the space within the mouth very small. In addition, the mouth opening could be small by itself. It's important for us to know if the patient can sublux their jaw, that is, jut their jaw outward. We also look in the mouth at the uvula and the soft palate. We check the distance from the throat to the chin, called the hyomental distance. And we have a particular interest in head and neck mobility. When we look in the mouth, we use a classification system called the Mallampati classification. Mallampati really is telling us how much of the back of the throat we can see when the patient opens their mouth and says, "ah." If we can see the uvula, or even part of the uvula, that's associated with either a class 1 or a class 2. We know that patients that have class 1 or class 2 views often have a more direct route from the mouth to the vocal cords and the airway for placing a breathing tube. Those patients where you cannot see the uvula, or even, maybe not even the back of the throat, we know that those patients are associated sometimes with difficulty in placing a breathing tube because we can't see from the mouth to the vocal cords using a laryngoscope. The high arched palate is depicted here. Generally, it appears that the top of the palate is much higher above the teeth than, say, a person who does not have one. This is associated with ATS. This is a close-up view. You can see sort of a deep recess, but it's not so much that the palate is high. If you notice that the teeth on the sides are closer together and that the upper part of the mouth is much more narrow, and it gives the appearance that the palate is high. But what we're really interested in as anesthesiologists is how wide the palate is, because a narrow palate gives us very little room to use when we're putting in a laryngoscope and ultimately a breathing tube. So if things are very narrow, we have less space. This is a depiction of a laryngoscope and a view inside an unconscious person's mouth. And those two little things that you see in the middle are the vocal cords. And the person, the anesthesiologist, is holding a laryngoscope, which is really nothing more than a fancy tongue blade made of metal with a light on the end. A high arched palate makes that person's mouth much more narrow. In fact, it may be so narrow that it only accommodates the laryngoscope. And attempting to put a breathing tube in may be complicated because there just might not be enough space for both a laryngoscope and the breathing tube. In an unconscious patient, especially one that's unconscious and facing upwards, the muscle tone becomes so slack that the jaw and the tongue fall backwards, and they close off the air passage from the nose down through the back of the throat and through the windpipe, and the patient can't breathe. You can also see the mouth is often occluded as well. This is a condition that sometimes is referred to as swallowing one's tongue, which is a complete misnomer. No tongue gets swallowed in this picture. It's just that the muscle tone is so slack that the airway occludes, and this patient is unconscious, so they make no maneuvers to recover. This arrow depicts the point of occlusion of the airway in the posterior pharynx or back of the throat. By lifting the jaw and bringing it upwards, one actually brings the entire tongue forward as well, opening this space and creating an air passage that can be used with a mask, for example, to push air into the trachea from the nose and mouth. Subluxation refers to moving the jaw joint. The TMJ, or temporomandibular joint of the jaw, is unique in that it works as a hinge, but it also can unhinge. For example, when someone takes a big yawn, the jaw comes out of its groove and slips forward, and that allows you to jut your jaw forward if you're asked to do so, but it also allows us to do so with an unconscious patient. So this is a depiction of someone's jaw, and you can see it has a hinge point there, which is used for just opening and closing. But to open your mouth really wide, that whole joint slips forward over the edge of the socket where the joint fits, and that's subluxation. Some people with joint disease are unable to do this, so they cannot open their mouth very wide. And in addition, If they're unconscious and we need to open their airway, we cannot use the jaw lift technique to bring the tongue forward. This is another skeletal depiction of where the edge of that jaw is as it comes out of the socket and comes forward. And you can see that the lower teeth are now well in front of the upper teeth. In order to look in someone's mouth and be able to see the vocal cords and the trachea beyond, we talk about 3 different axes. 2 of them are nearly in line already. So if you were looking from the back of the throat, you could almost see down the windpipe. But if you're looking in the mouth, you'd just be looking at the back of the throat. There is a positioning that allows alignment of these visual axes. And when that occurs, when you have that alignment, it means that you can look in the mouth and maybe see the vocal cords. And of course, when you see the vocal cords, the trachea or windpipe is right below that. By just positioning a person with the head extended and the neck flexed in the so-called sniffing position, we can get close to aligning these 3 axes so that we could look in the mouth and see the vocal cords. Typically, just doing this does not allow that view. A laryngoscope, as I mentioned, is sort of a tongue blade with a light on it and a handle. These are 2 examples of a curved type and a straight type. These are used to compress the tongue sort of into the jaw so that we can get that last little bit of tongue out of the way in order to look in the mouth while the patient is in the sniffing position and see the vocal cords. And if we can see the vocal cords, we can put a breathing tube directly through them, and we put it in with that little balloon thing down, the cuff, and then once it's through, we inflate that soft little cuff to help make a good seal so that we can breathe for an unconscious person, such as one going to have anesthesia. This is a depiction of the laryngoscope in action from the side view, and you can see that it's used to compress the tongue into this space below the jaw, which allows us to look between the upper teeth and the laryngoscope straight down toward the airway and the vocal cords, which would be right here, and this is the windpipe. So it's a straight view through here. The tongue is attached roughly between the ends of the jaw at the widest point. And it's attached to something called the hyoid bone. So if you lift the jaw forward, it brings the tongue with it. So someone who has a small jaw has less space in this area. And this space is important because the tongue needs to be compressed into this space with a laryngoscope so that we can see. By looking in the mouth, we can compress the tongue out of the way and we can see the vocal cords and place the breathing tube. So back to this picture. This is the laryngoscope compressing the tongue forward, and hence we can see and we can put the breathing tube directly in that direction. And it really doesn't look like what I just showed you, nor this really. Here's the vocal cords. If you look through the vocal cords, you can see the rings of the trachea or windpipe. This is the epiglottis, that little flap that is a trapdoor closure so you can swallow food without getting something on your vocal cords or in your windpipe. And this is what it looks like in real life. That upside down white V are the vocal cords. Trachea is below, and this is the epiglottis. So sometimes, even after lining everything up and using your laryngoscope, you may only see part of the vocal cords. This is a great view here. We call that a grade 1 view. And if we can only see the back half, it's a grade 2 view. We're pretty satisfied with either of those because we can usually get the endotracheal tube in fairly easily. Sometimes, though, all you see is the epiglottis. And if the epiglottis is really short, you can't really pick it up with the laryngoscope. So you can't really see the cords, but you know they're under there somewhere. And at other times, the view is so bad that all you see really is the base of the tongue and the back of the throat. And all this good stuff that you see in A is covered up and around the corner. We have a classification system called the Cormack-Lehane classification. And when we put a breathing tube in, we always make a notation in the patient's medical record of what the view was. So now I got a Mallampati grade for looking at the mouth, but we also have the Cormack-Lehane view, which is what we see after we actually get down to business and put the laryngoscope in. That's something that carries forward in the patient's medical record. Now, if we can't see anything with the laryngoscope, we have special fiber optic gizmos that we can use to see around the corner. This is a fiber optic bronchoscope. One looks through this end and you can see out this end, and there's a light that illuminates the path. And I'm depicting on the right side, putting a laryngoscope down that has an endotracheal tube on top of it. And if you go down and follow it along and find the vocal cords and go through, you can slip the endotracheal tube down over the bronchoscope into the trachea, and then take out the bronchoscope, and the breathing tube is left in place, in this instance through the nose and through the windpipe. So, important technique for finding one's way. Disadvantages are if there are a lot of secretions or if something's bloody in there, it may obscure the view and you can't see where you're going because the end of the fiber optics may be covered up with something opaque. There are other scopes too that use fiber optics. This is a laryngoscope that just has a more of a curve than we use for the ones that require direct vision. So instead of looking down here, we're actually looking at a screen, and it's using fiber optics to get the view right here. And we can go down and get this view, see what we need to see, and then we put a breathing tube in next to this scope, and we manipulate the breathing tube through the vocal cords by just watching this view, sort of blindly with one hand positioning it. We'll see the endotracheal tube come in and we'll position it through the vocal cords. And once we're through, then we take everything out and leave the breathing tube in place. So in an oral endotracheal tube, looks like this, goes through the mouth, and then sort of around the corner of the tongue, and then through the vocal cords into the trachea, and that little soft balloon then helps provide a nice seal for breathing. We also evaluate the lower airway. And of course we look at what happened last time with anesthesia and the breathing process. We also note the patient's usual respiratory rate. And we also like to look for tracheobronchomalacia. That's a big long word. It basically means somebody who has some weakness of the trachea or bronchial walls, the big airways that go to the lung. Sometimes that causes air trapping and difficulty with breathing, especially in an unconscious person. We like to know if that particular person has, when they're just doing their daily activities, shortness of breath, or if they've had recent lung function tests. We examine them, we listen for end expiratory wheezing, which could indicate airway collapse. We look at the shape of their chest, which sometimes gives us an idea of whether they have air trapping due to collapsing airways, or if they have scoliosis, another problem that ATS patients have, a curvature of the spine that sometimes restricts how well the lungs can expand. So this is a view down the trachea, and the trachea is kept open by these rings that are sort of shaped like a big C. On the backside, generally, there is not a ring. So, but the cartilage, each of these cartilage rings forms enough of a shape there that keeps the airway nice and open. You can see there's a whole series of those rings as it goes down to where to where it splits into the bronchi. If those rings are insufficient and they don't quite make a C, in fact they are just not even making quite halfway, then this back part of the trachea bulges into the trachea and it makes the inside much less round with much less space. And as the patient breathes out, the pressures in the chest are sufficient to push this wall of the trachea in and then restrict the air from leaving the lungs. So when the patient goes to take a breath in, this will open a little and let some air in, but since the old air was still there, they can't take as big a breath, and so they have air trapping. This is a depiction of how that would go. In a normal patient, there's a little bit of an indentation there where those rings don't come together. But in a person with tracheomalacia, where the cartilage is not quite enough of a circle, then they can have some pretty severe narrowing during exhalation. Inhalation, everything in the chest tends to expand. Exhalation, it all collapses. And unfortunately, it doesn't let the air out when it does that. Another depiction yet besides this one in the bronchus, where there's collapse on exhalation, it would result in air trapping in this case, in the left lung as the patient breathes out. The right lung in this depiction is unaffected. And this is a depiction of scoliosis. You can see how the spine is deformed. It shifts the ribs. It brings the diaphragm, the breathing muscle up. It makes the space available to the lungs very small. So the lungs cannot fully expand, and as a result, they usually don't grow enough either. And the patient has a restriction and they can't take very deep breaths. And if you combine that with not being able to take a deep breath, but then also not being able to exhale fully with tracheo or tracheobronchomalacia, there can be severe limitations with breathing, either awake or unconscious, but especially unconscious. This is another severe photograph, and you can see that the rib function, which normally these ribs will rise and fall with a breath in and a breath out, likely does not occur sufficiently in this patient to be able to expand their chest to take a breath in. We also look at the heart and arteries. We look at the previous heart findings, the echocardiogram if there has been one, their exercise tolerance, and we're interested in their usual blood pressure, heart rate, and whether they have hypertension or not. Hypertension might be indicative of severe kinks and curls in arteries that are distal to where we're taking a blood pressure. So if the smaller arteries are kinked and not allowing flow, sometimes we'll measure higher pressure in a blood pressure cuff, say at the upper arm, because the flow just cannot be adequate enough without having high pressure. We look for the pulses, we look for veins for intravenous access when we place an IV. We listen for heart sounds and murmurs, which are indicative of perhaps congenital heart disease. We listen for the second heart sound, because if it's really loud, then it could indicate that there's some high blood pressure to the lungs that might need to be addressed. And we consider getting repeat EKGs or chest x-rays. This is a normal heart with a normal blood flow. And most of the time, these great vessels are intact in ATS patients. It's when they start branching out beyond the heart that the tortuosity due to overgrowth can occur. We look at the valves. The aortic valve is in the red oval, and the pulmonary valve is in the green oval. If there is high blood pressure, those valves slam shut with more force, and the second heart sound, which can be created by either valve, is louder. And so that's why the second heart sound is important. These are the vessels that go to the head from the aortic arch. And the patient on the left has ATS. And you can see that those arteries didn't really stop growing when they were of adequate length compared to the normal patient on the right. So they twist and curl and sometimes kink, and they can restrict flow to the head and the brain and create a high blood pressure requirement in order to generate adequate flow to the head and the brain. The higher blood pressure would be in the big arteries before it gets to the curlicues that are created by the overgrown arteries. And these are added angiograms. And here's a patient with ATS. And you can see that their blood vessels or arteries to the head have overgrown and have become curled and kinked and take a meandering path. Sometimes this can limit blood flow to the head and to the brain, as compared to the normal patient, which is viewed on the right. These are the blood vessels that are at the base of the brain. A normal patient on the left has we call it the circle of Willis, an anatomist. And this is sort of a general staging area for blood as it goes to the brain on both sides. And in a patient with ATS on the right-hand side, you can see that there are more curves and twists and possibly kinks that exist there. And those get worse with time as those vessels continue to grow. This is why repeated examinations of neurological function and heart function and lung function are important over time, because these items do progress sometimes. And additional photographs of blood vessels that are going into the upper body in ATS patients, and lots of curvature. So ATS can also cause weakness in some other tissues that keep organs in place. Hernias can happen when bowel passes through an opening in the normally tough covering of the abdomen, and that hernia, or bowel usually, can escape into the soft tissue beneath the skin as it goes through this tough covering, the fascia. The trapped bowel, once it's out there and it's through this hole, can require emergency surgery because it starts to strangulate. The hiatal hernia is another kind of hernia that happens through the breathing muscle, the diaphragm, between the chest and abdomen. And sometimes there's just a little too much space in that area, and the stomach can actually start to migrate through this hole and become trapped in the chest. And that is a painful condition that sometimes can cause some esophagitis and upper abdominal pain. Often they have gastroesophageal reflux, because once this is up here, there's extra pressure, and acid that's produced in the stomach can then enter into the esophagus and cause a burning. The urinary system is also affected. Kidney problems, urinary problems. Sometimes it's really hard to get a Foley catheter in place during surgeries completely unrelated to kidneys and bladder. Obstructed kidneys can ultimately result in decreased kidney function, or create conditions for kidney or bladder infections. The lining of the urethra is often wrinkled or less smooth, and particularly in males, it can be difficult to get that Foley catheter to track through the urethra to the bladder. Sometimes we have to call a urologist to place the catheter for, say, cardiac procedures or things that are going to last longer than 3 hours, say, prior to the start of surgery, but after we've begun anesthesia. And the urologists are certainly very experienced with passing difficult Foley catheters. Irregularities and dilations of the path of urine are sometimes present with ATS. So the connections between the kidney and the bladder, the ureters, can be abnormal. There can be irregular divots in the bladder. There can be false valves, such as posterior urethral valves, that prevent the bladder from completely emptying. These things can cause repeated bladder infections. There can be thickening of the bladder wall with these little out pouches. So lots of things there that can impair function or prevent complete emptying, setting up a condition for repeat urinary tract infections. Skeletal abnormalities are known as well. There can be joint limitations, inabilities to completely extend, or fixations in flexion. There can be arthritis. There can be dislocations or joints that easily dislocate. Some of our patients with ATS cannot really lie flat, and they need some bolstering with pillows or padding. We like to know what the patient's normal range of motion is, especially for the head and neck and the limbs. Because while they're unconscious, we don't want them to be in a position where it's going to place a strain on a joint or tendon or muscle, so that when they awaken later or emerge from anesthesia, they don't have pain from malpositioning or being in a position while unconscious that creates a painful condition after they regain consciousness. And this is just an example of a child who cannot fully extend his arms. And knowing that degree of ability is important. Same for scoliosis. Sometimes we need to pad the patient's back so that all the pressure doesn't perhaps lie on, one side of the chest versus the other. By having a child bend forward, we can often get a better idea of the severity of rotational scoliosis, so that we know how better to pad that patient. Frequently, I like to have patient lie down on the operating bed or the MRI table or whatever we're going to use, and then ask them, as we put pillows and padding in, when they are most comfortable. So sometimes they'll tell us, well, I need a little more under my low back or something like that, and I really use their feedback to get an idea of what adequate padding is like for them. We look at the skin closely too. Wound healing can sometimes be problematic. Sometimes it's really hard to put an IV. Sometimes they have a history of easy scarring, so we want to avoid anything that, maybe if we usually suture lines, we may opt not to if they have a lot of scarring from tissue access. We look for unhealed wounds and visible veins for IV access later. So for anesthesia, we have the airway considerations, upper and lower, special fiber optic equipment we may need for putting a breathing tube in for intubation, considerations for tracheal or bronchomalacia, namely air trapping. Sometimes we don't really need a breathing tube. We can use other airway devices, such as laryngeal mask or just a mask case, or maybe we can just do sedation and let the patient have a nasal cannula while they're asleep and doing their own breathing. Often less is better. With the heart, we need to know what the function is like, what their normal baseline function is like when they're running around at home. If there's any restriction to coronary artery flow, that's important because the coronary arteries can be involved as well. And if they've got some impairment of flow to the heart, they may have angina at baseline. We look for aneurysms, things that may burst if the pressure is too high. Perhaps we'd ask for better blood pressure control before they come to anesthesia. And we're also interested in that high blood pressure to the pulmonary arteries or pulmonary hypertension. There's attention to the urinary part, especially with placement of the Foley catheter and need for a urologist, and the padding for the skeletal anomalies and limitations for placement of their joints and head and neck for that matter when they're going to be unconscious for any procedure. And the intravenous access is important. I always like to have a 2D ultrasound machine available so that we can see veins that are not visible at the surface of the skin, particularly veins that may be straight enough and big enough to accommodate an IV catheter. Considerations for monitoring during anesthesia include maintaining the blood pressure close to what the value is when they're awake, running a 5-lead ECG during anesthesia just so we can be aware of any parts of the heart that may be not getting enough blood flow. Invasive arterial pressure monitoring can be difficult because sometimes the arteries are just not straight enough to put a catheter in. We can use the ultrasound machine to see if the arteries are straight or if there is a portion of them that may be adequate for placing an arterial line. There are newer non-invasive continuous blood pressure monitors that provide a beat-to-beat blood pressure, but they're generally only available for patients that weigh 40 kilos or 88 pounds or more. So the small kids and the babies don't really have another kind of equivalent monitor. We like to use continued tissue oxygenation monitoring, or NIRS, near-infrared spectroscopy. It tells us what tissue, how much oxygen is going to various tissues with patches that are placed on the skin. And then Foley catheters give us an idea of how the kidneys are being perfused by measuring urine output. So this is an example of non-invasive continuous blood pressure monitoring. And it basically is measuring pulsations in small arteries in the fingers and correlating that with central blood pressure. So designed for big people, nothing available yet for small people and infants. This is the near-infrared spectroscopy. Patch is on the head, shines two versions of infrared light through the head, catching, for example, part of the brain in this case, and giving us an idea what the saturation of oxygen is in the brain at that area. We often put a second one over a muscle, maybe the low back muscle, to get an idea of tissue saturation at the same time. And this is what the monitor looks like. It can read up to 4 different patches on various parts of the body. Typically we use 2, one on a forehead, which gives us the brain and the frontal part of the skull, and then another one somewhere else, perhaps on the low back. Nerve blocks can be really valuable for patients with ATS. They minimize the amount of narcotic pain medicine they're going to need. They breathe better. They're less sleepy. They have better air movement. I think they recover faster. We inject the local anesthetic numbing medicine around a nerve. And although there is a risk of injecting into a twisted artery that may be next to a nerve, we use an ultrasound machine so that we can see where we're going and where that anesthetic is going. Some blocks are around nerves that aren't next to big arteries, and of course those are awesome as well. Epidurals and spinal blocks are a little more difficult to avoid vessels because we really can't see very well through the bone where we're putting those particular catheters. This is an example of an ulnar nerve block, and here's the needle, and the ulnar nerve lives right there, and there's the artery. We can see it. It looks like a black circle, and we can go right next to the nerve, and then we can inject some local anesthetic, and that actually makes the nerve sort of appear because this numbing medicine is sort of floating around it. But it's much safer now that we have high resolution two-dimensional ultrasound now for regional blocks. And I think it really is a way to go for many patients, especially older patients who may need nothing more than a good block. So the post-anesthetic care is a continuation of everything that we do. We like to continue using the same kind of monitoring that worked while they were anesthetized. We optimize their breathing and their airway patency, and we make sure that their pain is well controlled. We really like to focus on non-narcotic pain relief because it doesn't depress breathing. So non-steroidal anti-inflammatories such as ibuprofen, as well as acetaminophen, are often given prior to the end of the procedure. And if we're going to use a muscle relaxant, we like to use something that has a short duration of action and something that we can completely reverse when we're finished, so that there is no muscle weakness left over. And our handoff to other medical personnel who will be caring for the patient after the anesthetic really needs to be thorough and complete, so that we educate them as well about the facets of ATS and what they should be aware of when we bring them a patient. It's a relatively newly recognized disease, so education is the best option, and we can help facilitate that as perioperative care specialist, the anesthesiologist. So in the future, we need more definition about the course of the disease as it progresses. It would be great to have a better idea of how often certain complications occur and what their prevalence is, what other organ systems may be involved, or how the severity or how the disease progresses with other organ systems. And I say other organ systems just because it includes everything besides the airway that we're interested in. The metabolism could be varied too, depending on the effects of the disease on the kidneys and the liver. And then, of course, advances in alternative monitoring and new machines and gizmos that help us with anesthesia. Ultimately, we need to publish and share information so that people are more aware of this disease, and especially for anesthesiologists. So in summary, each patient gets a designer anesthetic, and we do that by knowing their medical history, their previous anesthetics, their medical issues. We do a thorough examination, and we specifically plan for that patient by having special equipment as needed, special monitoring as needed, and then individualized positioning during the procedure, and postoperative care as a continuation of our intraoperative care. So a lot of things that are going on for anesthesia for ATS. Sometimes there's so much focus on the procedural studies or surgical interventions that the anesthesia part sort of, is something that's not immediately apparent until someone needs anesthesia. So hopefully this lecture helped enlighten you a bit. Thank you very much for this opportunity to present this.